Dr. Hitesh Kukadiya.
Yes, you can start.
Yeah, good afternoon to the faculty and all my seniors and dear colleagues. Myself, Dr. Hitesh Kukadiya, am going to present an outcome of fixation versus excision of radial head in displaced radial head or neck fractures in a study of 50 cases. So the keywords are displaced radial head and neck fractures, Johnston's classification, low profile radial head blocking implants, Mayo elbow performance index, and radial nerve palsy. So coming to the introduction, radial head and neck fractures are fairly common and amounts to almost 25 to 30% of injuries around the elbow. Mason first described the fracture in 1954 and also advocated removal of the all radial head fractures in all cases when it is type 2 or 3 Masons. Majority of radial head fractures are simple and reducible even when not communicated. So main aim in radial head and neck fractures is restoration of radiocapitular contact point in coronal and vertical plane for the best possible functional outcome. Importance of fracture characteristics imparting to treatment include fragment number, fragment size, percentage of articular displacement, fragment comminution, fragment stability, displacement and corresponding block to motion, articular impaction, radiocapitular malalignment, radial neck and metaphyseal comminution and or bone loss. Anatomical studies have shown that the relationship between radial head center with the capitulum and olecranon sigmoid notch needs to be precisely restored during the radial head fixation or replaced by prosthetic replacement to optimize the outcomes. Many implants have been used to restore this anatomy till date. Many evolved over a time and were out of the practice. The implants which have been used till now are K-wires, simple 2.4 or 2.7 mm screws, mandibular low profile plates, anatomical radial neck plates, low profile radial head locking plates, celastic radial head prosthesis and metallic radial head prosthesis. The material and methods, we consecutively studied 50 cases of displaced radial head fractures over a period of 4 years from July 2013 to June 2017. The classification system was used was Johnston's classification. The only criteria for exclusion for us was skeletal immaturity and those which were not falling in Johnston type 2 or type 3. The pros and cons of excision versus fixation were explained to the patients and audiovisual consent was taken from patients and 2 relatives. 3 patients opted for excision and 27 for fixation. Surgical approach for both the procedure was same, that was Cocker's approach under brachial block anesthesia and with sedation as and when required. Capsule was cut in zigzag fashion in all cases. We want for provisional fixation using 1 or 1.5 mm K-wire and the fracture was stabilized finally using definite implant fixation. Stability of radial head and radiocapitular alignment in epi and lateral plane was confirmed on table using C-arm. First dressing was done 48 hours and then patients were discharged with oral analgesics and antibiotics. The final evaluation was done at 9 months using Mayo elbow performance index. Our results were categorized according to excision and fixation group. So excision group N1 is 23 and fixation group N2 is equal to 27. Total patients lost to follow-up were 5. Infection were found in 2 patients in fixation group while in 1 patient in excision group. Elbow stiffness were present in total 6 patients, 3 in both the groups. Flexion contracture was found at 9 months in 1 patient in excision group. Hardware-related problems were present in 2 patients in fixation group. Signs of late ulnar nerve palsy were present in 2 patients in excision group. Asymptomatic non-union was present in 1 patient in fixation group. Overall patient satisfaction was rated according to excellent, good, average or poor. All 3 patients, infections subsided with local debridement and dressings. All 2 posterior interosseous nerve palsy were gradually recovered within 9 months. Overall patient satisfaction was better in fixation group and particularly in those patients having 2 or maximum 3 fragments and large in size rather than those with small comminuted fragments. Our conclusion was that we compared our results with some meta-analytical studies. The outcomes were rated according to Mayo Elbow Performance Index, and categorized as excellent, good, fair, or poor. Though primary excision was advocated by Mason in all Mason type 2 or 3 injuries, with evolving low-profile implants and increasing surgical exposure of the junior surgeons, fixation can be a better permanent solution for fractures with less comminution and larger fragments. So more studies with larger sample sizes would be required to establish superiority of fixation or excision, but ultimate perspective should be stable, mobile, and painless elbow to carry out any surgery, may it be excision, fixation, or prosthetic radial head replacement. So here are some of the references. And I wish you all Merry Christmas and Happy New Year in advance. Thank you all, and thank you, Team Vaira.
Thank you, Hitesh, for finishing on time. Your experience says last year also you presented a paper on this topic.
No, sir. That was meta-heuristic.
Okay. It's open to questions now. Yeah, Dr. Antau will like to ask.
Doctor, nice study, but we have not seen any functional results in terms of pictures of the patient and also your operative X-rays and all, no?
Yes.
Could you...
Sir, actually I got the X-rays, but I got it in 2003 format, which was not working with the 2010 format. Sorry for that.
Hitesh.
Yes, sir.
Hitesh, I had one question for you. At your age, if you get a radial head fracture with a Mason type 3, would you want it fixed, excised, or replaced?
Sir, actually, this was based on Johnston's classification, but Mason's classification according to type 3, it also includes sometimes fractures associated with complex elbow injuries, which may include dislocation as well as ulnar capitular fractures as well. So, which were not included in this classification. So that's why we use Johnston's classification.
We have a question from the back.
Just one doubt. What is the reason of ulnar nerve palsy in case of radial head excision?
Sorry?
When you excise the radial head...
When you excise the radial head, why was there ulnar nerve palsy?
Sir,
You reported 2 cases.
Yes, sir. Yeah. That is due to valgus instability, which ultimately leads to posterior chronic...
So was it like a tardy ulnar nerve palsy?
Tardy ulnar nerve
It
palsy.
happened later.
Late ulnar nerve palsy.
Okay.
Dr. Agashi, would you like to ask a question?
No, I felt 50 number is a huge number for radial head. In fact, you should be the one to give us guidelines rather than saying that larger study is needed.
No, sir. Actually, that was total number, 50 number. Total fixation were 27. 2 were with Herbert screw, that is 2 4 mm Herberts, and 12 around were radial neck plates, and 2 were mandibular plates, and rest were low-profile radial head plates. 23 were excision.
Thank you so much.
Thank you, Hitesh. Please come and collect your certificate.